Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
For me, the pleasure to be here for this symposium organized by the Lymphedema Education and Research Network. It is a fantastic tool to have this online symposium to share the experience, and I'm happy to share our experience. That is an experience of 50 years, because last year we celebrated 50 years. We started in 1973. And during the World Congress of the International Society of Lymphology, we celebrated these 50 years. It was really a fantastic occasion with people, physicians, doctors, surgeons, other health professionals coming from all over the world to share our experience on lymphedema and lipedema. So my topic today is lymphatic surgery and microsurgery at the Genoa Center. In fact, we have been dealing with these pathologies since the early 70s, and especially my father, Professor Campisi, in the 70s started to perform this kind of surgery. And as you know, at that time, the tools, instruments, microscopes, and also the treatment of these patients from the physical point of view was much different than now. So we can say that now we are happy and we are more lucky to have such tools that allows us to be very to have fantastic performances and outcomes after surgery. I thank a lot the Lymphedema and Lymphatic Education Research Network. I thank all the team. It's a fantastic network that really is present, I can say, all over the world. And I thank personally also my friend William Repici, that is running the LE&RN in a fantastic way. And really, it is for me an honor to be here and to speak about our experience. I can say that lymphatic surgery today is something that is coming more and more often in different places around the world. There are new lymphedema clinics, and now lymphedema clinics are based not only on physical treatment, but also in lymphedema surgery. Of course, I have to say also that we have to thank all the sponsors that support LE&RN Symposium series. And to start, I have also to say, and it's a pleasure for me to say, that recently during the World Congress of the International Society of Lymphology that I had the honor to host in Genoa last September, from 11 to 15, 2023, I had the honor to be elected as president-elect of the International Society of Lymphology. We work our places where we work mainly are in Genoa, in Italy, and recently I also opened a new center of lymphedema and lipedema treatment and surgery in Switzerland, and I'm working very well. So there, I'm trying to do my best to help patients that have unmet questions and needs, especially those ones that are affected by lymphatic diseases, both primary and secondary. I'm happy to share this experience. I don't have disclosures to declare. And as I said previously, I'm happy to be part of the International Society of Lymphology. I started to attend the meetings when I was young. I was a medical student, and it was for me a great honor to be elected as the next president during the International Society of Lymphology meeting in Genoa in 2023. So to start and to understand the way we approach to lymphatic diseases in particular, I have to say that the treatment is a mix of non-surgical and surgical. So this was also the topic of the World Congress of Lymphology, was bridging the gap between physical therapy, between the non-surgical procedures to treat lymphedema and surgical procedures. Because in the past, I would say, of course, less than now, there were like two schools of thinking. One was that lymphedema had to be managed only with surgical procedures, and one school there was another in the past in which lymphedema surgery was proposed as a possible solution to lymphatic disease. Now we are getting closer and closer, and for sure, we always consider that the phase 1 treatment is based on physical treatment. So physical treatments that we consider that they are extremely important and functional for patients. So we don't have to forget about that. So a teamwork is really relevant to help the patients in the best way. In our clinical experience, if we experience patients that perform 6 to 12 months or more physical treatments without let's say, a non-optimal result, we take into consideration surgery. Surgery today, with the diagnostics that we have available, helps us to decide the correct indications. So we can decide for a reconstructive surgery, we can decide also for a debulking surgery, and now the debulking surgery are less and less invasive in comparison to the past. And of course, these diseases are diseases that are chronic, become chronic. And so the follow-up in these patients is really relevant, fundamental for the best possible result according to the type of lymphedema, the stage, and also to the story of the patient. So when we decide to approach to lymphedema patients, of course, we have to take into consideration the staging. We know that the staging can go from really latent lymphedema, stage 1A, through a lot of other evolution of the disease that goes up to the extreme elephantiasis. And now into 2024, we have to know that we have to avoid with primary prevention and secondary prevention, that means early diagnosis, the evolution of the disease. And for those patients that have a very advanced lymphedema, also the tertiary prevention is important. So it means the prevention of all the complications that lymphedema has, such as infections, and also all the other possible complications that create a huge grade of disability of these patients. So, of course, this is another, let's say, important concept. The surgery should be anyway performed as soon as possible when physical treatment or other non-surgical treatments are not effective and the lymphedema is worsening. In the picture on the left, you see an initial lymphedema, and the picture on the right, you see an advanced lymphedema with a huge deposition of fibrotic and inflammatory tissue. And this makes the disease for sure more difficult to be reversible. And the other techniques, not only microsurgery, could be necessary to achieve the best clinical outcome. Another point that I want to underline, because we have performed recently a very important study with LymphaPress, because we wanted to see what was the effect of the different possible non-surgical treatments in preparation to surgery. And what we have seen is that the best treatments are nerve treatments, complementary treatments altogether. And what we're seeing particularly is that applying the intermittent traumatic compression together with bandaging, lymphatic manual drainage, so adding this IPC mechanical lymphatic drainage, the volume changes preparatory for those patients that were addressed to surgery were considerably better than those patients on which this kind of therapy was not applied. So, of course, surgery can help a lot, but also preparation, diagnosis, and planning is fundamental before surgery to address the problem of each patient. So this is an example of a very advanced lymphedema. This is a patient that had been coming from the States. I took it on purpose because, this is a case that is very advanced. This patient came with such situation, and so the questions that were raised were, we just perform physical treatments or microsurgery, liposuction, or other debugging the surgeries. And in this situation, even in such advanced cases, we can find suitable lymphatic vessels, like the one that you see here. A suitable lymphatic pathways still patent and functional, that can be used in a very effective way to perform a lymphatic venous anastomosis, so a lymphatic venous reconstruction. So the concept is that lymphatics can be found also in very advanced cases. And for this, we have many tools. We have lymphoscintigraphy, that still is an exam that has to be standardized in a better way. We have ICG macrolymphography. Now we have also the ultra high frequency ultrasound, the probes that go up to 70 megahertz and help us to see if lymphatic vessels is functional or non-functional. So this was the immediate result after surgery of this patient. So you see that this is a few days after the surgery, the scar, so the incision the skin incision is very small, and the incision was performed in the groin area to drain all the lymphatic system in the venous system from the groin area. So this was an example to say and to explain how do we make decisions. So we make decisions according to the, of course, story of the patient, the type of lymphedema, if it's primary or secondary. If it's an lymphedema in a very young baby, or lymphedema in an adult, a woman, or lymphedema in elderlies. And we can use all these tools. And honestly, the ones that we use the most are ICG lymphography, lymphoscintigraphy, and now, since few years, the ultra high frequency ultrasound. And this helps us to make decisions according to each kind of lymphedema. And what I've learned so far is that every case is different to the other one. I mean, we can, let's say, make categories, but in general, the planning, surgical planning in each case, and also the response to each case is really unique. Before I said surgery, possibly as soon as possible, because in early lymphedemas, especially when lymphedemas are not associated with a malformation, so few lymphatics or few lymph nodes. You have very dilated lymphatics due to the lymphatic hypertension, and this is the best phase for acting, the best phase for performing surgery and microsurgery, because these vessels have a high flow and the anastomos can work very better. And in terms of volume reduction and consistency, long-term consistency after surgery, we can obtain fantastic results. So it is very important, very strong collaboration between the therapist and the surgeons to set the correct timing for surgery, avoiding the disease to progress and become more and more chronic. And in these cases, of course, the structures, the vessels, the lymphatics, but also the nodes go, and the lymph nodes go through a huge state of inflammation, and this damage the structures. The anastomos, the microsurgical reconstruction we perform the most is the multiple lymphatic venous anastomos. This means that, as you see in the picture, multiple vessels, multiple pathways are anastomos with a vein. And the veins that are used are mostly veins that have a greater caliber. These are not usually veins, but are veins that are greater caliber, and they can host multiple lymphatic pathways. And in this way, the strength and the flow through the anastomos is working in a very important and considerable way, because the vein system without vein reflux hosts all the lymphatic flow through the different pathways that are anastomos in these multiple lymphatic venous anastomos. And the sites that we use the most are the groin or the inguinal region for the lower limbs and the brachial region close to the axilla for the upper limbs. Of course, the surgery can be applied also in other parts of the body for abdominal lymphedema, genital lymphedema, lymphedema of the thorax, lymphedema of the abdomen with callus ascites, and also in the head and neck lymphedema. In this way, we can act at different levels. What does it mean level 1, 2, or 3? How much deeper we go? Level 1 is the one that is close to the skin. 2 is the level that is still superficial, but is deeper. In the lower limbs is the level of the saphenous system, so the superficial vein system. And level 3 is the real deep level under the muscle fascia. And this is the same also for upper limb lymphedema. In this picture, you see the vein and two nice, very deep lymphatic collectors that run close to the median nerve. And this case was the case of lymphedema related to breast cancer. Here are some examples with the post-op control of the anastomos patency with the ICG flow. We can control with the ICG, we can control with the lymphoscintigraphy, and you see the fluorescence through the anastomos, and you see also the vein valve that is working properly because there is no reflux, so there is one flow from the lymphatic system to the vein system that is working properly. These are other examples that you can see freestyle because we can adapt ourselves to the situation where the lymphatics are in the surgical field, where the veins are. And so it's really, as I said before, every case specifically is different. Another example, the ICG flow, you see the patency. This is a very good sign post-operatively. Other example of multiple lymphatic venous anastomos with high flow and patency. You see here, this is another example. This is the upper limb. You see even a single lymphatic pathway that mainly contains more than one lymphatic collector that is functional, can help us to have a fantastic flow through the anastomos. Other examples, sometimes we put on purpose the clamper on the proximal part of the vein to help the anastomos to get full of lymph and then remove the clamper. And this way, there is a non-contact through the anastomosis segment between blood and lymph. Other example, freestyle, in this case, we perform 3 different anastomoses. So multiple lymphatic venous anastomosis means also possible different sites according to the plane where lymphatic is and according to the vein system that is studied every time in a very specific way preparatively. And this is an example to say that sometimes at conferences or patients that come for consultation, they ask what is the long-term patency of this lymphatic venous anastomos with time. And we have a lot of cases. We study this a lot with seeing, of course, the clinic, the volume reduction, the outcome of the patient, and of course, performing other exams such as lymphoscintigraphy. And in this case, we have a very old, and I'm sorry for the pictures, but it's very old and was not digital lymphoscintigraphy, in which you have like really a severe impairment of the lymphatic flow on the left limb. And in the lymphoscintigraphy that was performed last year, you see on the left this lymphatic pathway that was going through the ground that was not possible to be seen in 2011. So this is an indirect sign of lymphatic venous patency. And it is very important to make a good plan to select good lymphatics with a good flow and a good vein system without vein reflux. And this is the case of the patient that came to our attention a long follow-up because it's more than 10 years after surgery. We can provide mixer. We can use a direct wall-to-wall end-to-end or end-to-side lymphatic venous anastomos. We can use the multiple lymphatic venous anastomos anastomosing different collectors to a vein, and we can adapt it according to the situation, the caliber of the structures, and the presence of good lymphatic collectors. So going back again to the stage and seeing how much these treatments can improve the patient perspective from primary prevention to advanced cases. An example of that of primary prevention is the one of LE&RN. LE&RN is an acronym for Lymphatic Microsurgical Preventing Healing Approach. And this was first described for breast cancer lymphedema. So the goal was to prevent lymphedema after breast cancer treatment, and in particular, lymph nodal removal of the axilla. And but this concept of prevention can be applied, of course, to oncologic surgery, not only breast cancer, melanoma, and other cancers like uterine cancer, prostate cancer. Can we apply also to other surgeries that have a high risk of developing lymphedema? Hernia repair, like inguinal hernia repair, tiny sentinel node biopsy, saphenofemoral prostatectomy. The procedures to do a cardiac catheterization via femoral artery, they have a lot of complications with a lot of lymphoria and possible also developing of lymphocyte and secondary lymphedema. Also, lymphoma surgery in areas that in which there are a huge concentration of lymphatic lymph nodal structure. So the evaluation is important. Patients are at higher risk where they have a body mass index that is higher than 25, even worse if it's higher than 30. Pre-approval lymphoscintigraphy helps to understand if it is a patient at risk, especially if the patient has an impaired transport index. Intraoperatively and eventually post-operatively ICG test is also very important to understand, to map the lymphatic structures, and also to prevent lymphatic lesions, but not only lymphatic lesions, lymph node lesions, and also to understand if a patient has an existent lymphatic hypertension that is a sign of latent lymphedema. This is an example where a groin lymphocyte was iatrogenic, so a lymphocyte after surgery. We removed the lymphocyte of the groin, but the lymphatics that were afferent to this lymphocyte were anastomosis at the same time the lymphocyte removal with a secondary lymphedema, because you remove the lymphocyte, but those lymphatics that are after to the lymphocyte should be preserved and possibly anastomosis to avoid the secondary lymphedema. Secondary prevention means early diagnosis. Early diagnosis means possibly also early treatment. And then this can be applied to primary lymphedema and also to secondary lymphedema, also to congenital lymphedema. For example, we have a very important case history of lymphatic microsurgery in babies. This is a 12 years old baby from Europe, from UK. But we have a huge experience also of babies that are younger than 10 years old. And so, I mean, also in this case, if the lymphedema is fastly growing, it's important to avoid the lymphedema to become worse and worse. And in these cases that are very fast, that have a fast evolution, the option of performing lymphatic microsurgery should always be considered. This was the case of the baby. You see, this is a blue anastomosis because we use the blue pattern dye together with ICG. Another topic is that we have seen there are some cases in which the blue helps to find lymphatics that may be ICG negative. And can happen also that there can be some lymphatics that are ICG positive, but are blue negative. So we think in our case history that performing both injections helps the surgeon to get the best possible information to select the lymphatic structure for microsurgical reconstruction. The outcome can be excellent adding the physical treatments, correct timing for surgery, and post-op care, both in primary lymphedema and secondary lymphedema. I show you some pictures of long-standing follow-up because this is a chronic disease. In this case that I show you, for example, this one of the battery procedures was performed just physical treatment and microsurgery. This is a primary precox lymphedema with 15 years follow-up. And we can see another one on follow-up, 13 years follow-up of secondary lymphedema following uterine cancer treatment. Breast cancer-related lymphedema, like now, is less common, but still present, also after sentinel node biopsy. At the World Congress of Lymphology in last September, we had a session with also the past president of the American Society of Breast Surgery, Sheldon Feldman, and many casualties telling us that still there is an incidence of secondary lymphedema after sentinel node biopsy that can go up to 13% of cases. So in these cases, for sure, anatomy has to be considered, body mass index has to be considered, the treatments, radiotherapy, and lymph node removal, but also anatomy should be considered. So planning with ICG, planning with lymphoscintigraphy before lymph node removal, even if it is only a sentinel lymph node biopsy, should be offered to patients that are at higher risk of developing limb swelling. These are other examples of non-follow-ups after breast cancer-related lymphedema. Another thing that, because I want to speak about things that are, of course, new in this presentation, we have been doing a study on lymphatic regeneration because these scaffolds of lymphatic reconstruction were used in lymph node transfer, vascular lymph node transfer, but never in together with the lymphatic venous anastomosis. And we did this study in particular analyzing 30 patients, 15 that underwent microsurgical reconstruction and 15 that underwent microsurgical reconstruction, lymphatic venous reconstruction with back bridge. And now we are performing all the analysis of these patients that are telling us, especially we are performing ICG and lymphoscintigraphy postoperatively at from 6 months to 12 months after surgery. And we have seen so far, controlling the volume measurements of these patients, that so far the patients of the treatment group had a better outcome with using the regenerative scaffolds in comparison to the group of microsurgery without implantation of back bridge. This is something that will come out on a paper. The paper regarding the use of intermittent traumatic compression before surgery with all the other complementary treatments is coming out in the journal Lymphology. And what I want to speak for the rest of the time I have, let's say a few more minutes, is the question, what do we do with the fat, fibrotic or inflammatory tissue in lymphedema patients? So microsurgery, physical treatments, occasionally, correct timing, microsurgery, but the fat, the fibrosis, the inflammatory tissue, when it's a long-standing lymphedema, is still there. And this tissue, of course, is something that exposes the patient to high risk of inflammation, acute inflammation, infections, and in terms of volume reduction, is a tissue that should be removed. So what we studied is performing, let's say, a reconstructive liposuction after microsurgery. Our concept was we reconstruct and then we perform liposuction, but which is the type of liposuction that can treat these patients that have a good results in terms of fluid removal, in terms of pitting, but still have this fat fibrotic inflammatory tissue. So that's why, and this is a case of a patient from Italy that had the treatment of non-Hodgkin lymphoma with a huge amount of radiotherapy and performed developed this lymphedema. We had a good result after microsurgery, you can see on the right, but still the presence of this tissue especially in the right leg. So that's why was first described more than 10 years ago. The article was published in 2016, but we started with our series in 2012 to perform a lymph vessel sparing liposuction. So lymph vessel sparing liposuction means preventing the lymphatic injuries with lymphatic mapping. Lymphatic mapping thanks to the ICG. ICG helps us to map the lymphatic structures on the site of that we want to perform liposuction. Can be in a leg, can be in arm, can be in other parts of the body. We do a lymphatic mapping. We decide where to perform the skin incision, and also the route of the lymphatic. We can follow the route of the lymphatic within the cameras in the best way of avoiding any lymphatic demolishing. Recently, was really in 2023, I added another type of lymph vessel sparing liposuction. So, lymph vessel sparing with lymphatic mapping with ICG for microlymphography and with ultra-frequency ultrasound mapping. But the other let's say ingredient is on this let's say liver aspirated liposuction that we want to add the ultrasound assisted liposuction. This means that ultrasound assisted liposuction can help us to avoid let's say some complications of liposuction, such as bleeding, such as problems of sensibility, like hypoanesthesia of some area of the leg. And another important thing helps us to make the soil tissue liquid and helping us to be more effective in terms of volume reduction with fantastic outcomes. Also in patients at high risk of liposuction. So ultrasound assisted liposuction has 3 steps: the infiltration of local anesthesia, the fermentation with the emulsification of the solid tissue, and aspiration. What we've seen analyzing the different types of liposuction through a standard one and the one with ultrasound is that we've seen that there were no injury to the lymphocytes, so the tissue was uniform, minimal blood cell component, no tissue distortion, and lymphedema with a huge deposition of fibrotic tissue, a predominant thrombotic component. This in comparison to standard liposuction. So the advantages so far that we've found applying this technique since last year in lymphedema patients, but also in lipedema patients, is that it reduces the trauma and minimizes the amount of blood removed compared to traditional liposuction. This means less pain, less swelling, less bruising, so faster recovery for the patient. And for the surgeon, despite a slight prolongation of the operative time, because the operative time is a little bit longer, it can be 15, 20, 25 to an hour longer in comparison to the standard liposuction. Ultrasound assisted liposuction can significantly reduce physician fatigue, especially in lymphedemas that have a huge fibrotic component. These are some examples. You see patients, you see on the right the perometry measurements and the DOM volume. And this is in the secondary lymphedema following prostate cancer after microsurgery. This is a bilateral primary light lymphedema that was treated with microsurgery bilaterally and then liposuction. And this is a case of Clipperton syndrome. We're using a lot also in such patients that have a high risk of huge bleeding because of the vascular malformations in the Clipperton syndrome. And we've seen that the bleeding during reduced to nothing, so the patient recovery is so faster, the risks are practically nil. And in terms of volume reduction after microsurgery, we gain fantastic and excellent outcomes. So I thank you for your attention. More or less, I took 30 minutes for this presentation, and now I am, of course, available to look at the question and answers for those attendants that are interested. Here I see a question from a patient from Ottawa, Canada, and he says, he's speaking about, of course, the problem of these patients all around the world, that especially speaks about 300 million people affected by lymphedema. And of course, the training, education, information in lymphology are essential to deliver good information to patients. And in this specific topic, I thank so much all the work done by LE&RN on this, because the daily work they do is really devoted to patients. And Here another question that asks me, when you are addressing extreme lymphatic or advanced lymphatic leakage, do you also consider the surrounding area and how it is affecting the lymphatics and if it is complicating the lymphatics? Example, what if the patient has protein build up around the area of lipedema, pushing on the lymphatics? Do you also look at the major lymphatic nodes to make sure they are not black or causing lymphatic complication? This is a very interesting question, and thank you for asking. Because many times we speak about lymphedema, we speak about lipedema. Some societies or patients associations around the world, they like to completely, let's say, divide the two problems, like lymphedema is lymphedema, lipedema is lipedema. But the truth is that in my practice, I see so many lymphedema. So these clinical conditions see both lymphatic impairment and adipose deposition. So those patients to get the best results, we perform all the study. We study the lymphatic system. Of course, we study the nodes. I showed before all the instruments that we are available, especially ICG and high-frequency ultrasound and lymphoscintigraphy today to address the problem. And of course, if there is a lymphatic impairment, we treat first the lymphatic impairment and then the adipose tissue. And another question here is, I had a severe case of lymphedema and I also have lipedema. And I was told by a doctor, because of the advanced stage of mine, I can have lymph vessel of lymph node transfer. He said my BMI is too high. I wear a size small on top. I was 325 pounds and now I weigh 225. It's all in my legs. Will you be able to do surgery or do you require certain BMI? I work compression and I do lymphatic pumps. So to answer to this question is that I should see your exams, so ICG, lymphoscintigraphy, and eventually ultrasound examinations if you have performed that. Of course, BMI is strongly related to lymphatic complications, but we have a huge experience with patients with high BMI. Of course, it is suggested for the patient to reduce the body mass index, but in a patient like in these situations that they need is 225 pounds, of course, we can perform lymphatic surgery, lymph node transfer, lymph vessel anastomosis, depends on your situation. Possibly, if there are functional lymphatic vessels, lymphatic leaders anastomosis is the first choice. And of course, to remove then after the adipose tissue, I suggest the lymph vessel sparing ultrasound assisted liposuction. Another question is something injected to give the blue appearance of the structure shown? Yes. Thank you for the question. I said before we use both the blue patent dye and the green doxin. These are two different tests. The blue patent colors the lymphatics in blue. The ICG shows the lymphatics that are functional fluorescent, lymphatics and lymph nodes. So these are two tests that are both very important and complementary, because as I said before, there are some cases in which some lymphatics are blue but are not fluorescent, or the opposite. Another question asked me, when is vascular lymph node transfer recommended for what stage and what are the results? So vascular lymph node transfer could be recommended when there are non-functional lymphatic structures. And the problem then, the concern regarding vascular lymph node transfer is the fact from where we harvest the lymphatics, because patients that have lymphedema, of course, primary lymphedema, but also patients with secondary lymphedema are at high risk of developing a secondary lymphedema if you take lymph nodes from the site that is at risk. So the study of the body is extremely relevant, is fundamental. Lymph nodes should be taken from places in which there is a very low risk of developing a secondary lymphedema. Another person asked me, thank you for this talk. Are the patients wearing compression garments permanently after the surgery? This is a good question. It depends on the staging. We register a huge reduction in terms of volume after microsurgery. The fluid component, so the lymph stages after liposuction, the adipose tissue, fibrotic tissue, and inflammatory tissue. This depends on the stage. Sometimes when the lymphedema is very advanced, the patient needs to wear compression and garments at least during the day. And there are some cases, of course, in which the lymphedema is very at the beginning, and we can discontinue or remove the use of the stockings. So this depends on the staging. That's why I said that ends up so as soon as possible. It is for sure a good strategy to act in a moment in which we can achieve better results and also faster results for the patient. Do the patients still need lymphedema management after the procedure? What's the long-term carryover? Yes, they do. They do. At least we say we do a follow-up 1 month after surgery, 3 months after surgery, 6 months after surgery, and then once a year for at least 5 years. So lymphedema management depends on the staging. Sometimes patients go just through lymph drainage or manual lymph drainage. Sometimes they need something more or bandaging. But the reason why we perform surgery is to reduce the need of the patient to perform post-operative continuous lymphedema conservative treatments, as well to reduce the need or also the cracks of the compression stockings. Another person asked me, can you address the surgical plan and prognosis and outcomes in patients with lymphedema with significant radiation fibrosis and damage? Yes, this depends always on the study of the patients. As I said, there are first lymphedemas in which you have functional lymphatics, and so in this case, the lymphatic reconstruction should be always taken into consideration. Can you do ultrasound assisted liposuction or real-world with girdle lymphedema and fibrosis bilateral? Yeah, it is possible, but in the genitals, usually we prefer to do a complete reconstruction. So to perform lymphatic reconstruction and all the plasty to remove all the lymphedema tissue from the suprapubic area, the genitals that can be secondary to the cancer treatment or also primary with a severe lymphatic reflux, sometimes cavity reflux through the abdomen. Another person asked me, do you think lymphatic mapping techniques could be applied to map lymphatic with solid organs? Yes, of sure, depends on where you inject the mapping dye. Another person asked me, thank you for your presentation. How do you perceive current awareness from patient and plastic surgeon community? Now we have a lot of tools, for sure. We have scientific tools, we have online tools, we have conferences on the world, local, European, in my case, or also around the world. Of course, there are social networks, there are websites, but the problem now that makes so much possible information, the problems that we have to fight. For example, in my position as the next president of the International Clinical Lymphology, but in general, all the plastic surgeon community is the fake news. Fake news should be absolutely fighted, and we should build them more awareness on evidence-based medicine. When we discuss the post-op treatment, does the patient still have to wear compression stockings? I answered to the question, let's say before, But to go a little bit deeper on that, after surgery, immediately after surgery, patient does a post-op physical treatment, and he goes home with stockings, and according to the stage, we perform follow-up consultation after 1, 3, 6, and 12 months. Depends on if the patient needs to perform a liposuction. If the lymphedema is advanced, then we can see the patient before, let's say 2 to 3 months after microsurgical reconstruction to perform an universal spinal liposuction. But as you know, lymphedema can be localized in many areas of the body. Sometimes one leg, can be 2 legs, can be the lower abdomen, can be also the upper limbs. So it depends also how much the lymphedema is widespread in the body of the patient. If it's one leg lymphedema, or unilateral lymphedema, in these cases, we evaluate if the patient needs a reconstruction or not. But the post-op management is, let's say, more important in the first phase after surgery, immediately after surgery, and then programming the follow-up, as I said, 1, 3, 6, and 1 year. And usually we see at least the patients once a year to evaluate the condition, because it's a chronic disease and we have to follow the patients. For example, there are patients that receive surgery are women before pregnancy, everything changes after pregnancy. So in these cases, we suggest the patient to come and to see us more often, because during pregnancy there are a lot of modifications can affect, of course, the lymphedema. Are the surgeries paid by insurance, or are they paid out of pocket by patients? In Europe, and I perform surgeries in Italy and in Switzerland, the surgeons are paid both by insurance, because in Switzerland there is an insurance system, and also are paid by the health system in Italy. So these are surgeries that they are not and not be paid out of pocket by patients, because this is a pathology and this is not an aesthetic procedure. I have a few more questions because I think I till 10 more minutes before I finish. And one that refers to a stage, an extension level lymphedema, and one large mass on each leg. The largest mass is half on a reduced size. Compression garments do not stay in place to this size, must be easily removed. So I don't say easily, because this is an important surgery, but yes, can be removed with liposuction, but can also be removed with a reconstructive procedure. The mass can be removed. We have a lot of experience on that, but of course, adding the removal of the mass with an eventual lymphatic reconstruction, if possible, is the best suggestion. And when in two patients already have the SAPR, where process is opposite to some other surgery, at least in the States, can patients who have a SAPLO still come to result for LBA? Yeah, it's correct. In the concept we apply is to perform liposuction after microsurgical reconstruction. We do not like to perform liposuction before, because some lymphatic structures, even if mapping the lymphatic system, can be damaged if you perform liposuction before. Because if you perform liposuction before, you as even if you do a lot of physical treatments and pitting edema, the sense of microsurgery is to remove the pitting edema, and the current indication for liposuction is to perform a liposuction on cell tissue and then non-pitting edemas. In the narrow lymphedema very, very soft, and sometimes the lymphedema can, in the later stage, have a severe lymphatic impairment, and lymphedema in the later stage can have a severe fat and fibrotic deposition. The fact is that also a lot of papers that are coming out now came out recently, but also of the past, shows how these pathologies are strongly related. And it is very common to see a light lymphedema. And in this case, to get the best result, we should treat both the lymphatic component and the fat component. And Dr. Campisi, how does diet affect the healing of the lymphedema patient? This is very interesting. There are coming very more studies on this, and so far I would say the diet is very important. Depends if the lymphedema is a lymphedema related to thymus problems, so intestinal bowel problems, but in general the diet affects a lot, because the lymphedema is inflammation, and there are some of course some types of food that of course promote the inflammation. So any kind of diet, such as some kind of ketogenic diets, but everything that removes inflammation, of course, helps the lymphedema process. So diet is important, lifestyle, exercise. So exercise means gym, but on top this means sports, means water. Also, a lot of papers and evidence-based medicine papers coming out with the importance of water for the treatment of lymphatics and venous diseases. Another person asked me, could I have the opportunity for short-term observership in your center as I'm interested in lymphedema surgery? Of course, more than welcome. Another person asked me, what is better to perform lymphatic microsurgery by liposuction of fibrotic edema? Is this specific to fibrotic edema? No, it's not specific to fibrotic edema. The cause is that the indication for liposuction is a limb or a place, can be lower abdomen, legs, arm, in which you don't have fluid retention, fluid component, you don't have hemostasis. So we know that the concept and the reason why we perform surgery is to treat this fluid component. And then we treat the adipose or fibrotic component. This is the physiologic way we act on this kind of diseases. We remove the fibrotic component, the fluid component, so the heating, and then perform liposuction. I had lymph node transplant, and then a year later liposuction with great results. The grew lymph vessels in leg. Some years later, a second liposuction, but was run as a surgery with no stretchy tape that cut into my leg. Results of fibrosis that is now very hard. Is there an experience with possible solution? Yes, there are different possible solutions that are non-surgical. There are some types of specific medical shockwave therapy, and there is a protocol that we developed in Genoa that help a lot with these areas that are really very hard and fibrotic. Eventually, the ultrasound assisted liposuction with specific ultrasound cannulas can help a lot with those areas that are highly fibrotic. What information and imaging would you like to have from the lymphedema therapist to evaluate if a patient is candidate for surgery? Measurements, lymphedema, light impact, say yes. Every information is useful. The start of the patient, if lymphedema is primary or secondary, and some information regarding tests, not only measurements like ICG, lymphoscintigraphy, not only lymphatic magnetic resonance, but ICG and lymphoscintigraphy should be enough to evaluate the patient. And also the response to physical treatment. I have both lymphedema, and if I can find a way for the surgery, I know that I need a microsurgeon. Do you know any qualified microsurgeon in Arizona? I honestly don't know any specific sample in Arizona, and mainly there are new centers that I don't know. But I can look it up. Even if United States are so big, still to set up an lymphedema clinic is a huge job. So honestly, I don't know from around. I don't know honestly their experience on their casualty, but I can check on that. Yeah. Another question about secondary lymphedema, and in this case, as I said, this patient said that 41 lymph nodes removed and extend the bilateral lymph node dissection post bladder cancer. And in this case, it's the consent is that to act as soon as possible, because in this case, the fibrosis inflammation is extremely fast, and there is a huge degeneration of the lymphatic structures. We have to remember that when you perform this kind of surgery, when you do an extended bilateral lymph node dissection for bladder, we remove lymph nodes that are in the abdomen, in the pelvic region. You don't touch the nodes that are in the groin. The nodes on the groin are disconnected to the one in the pelvic region. So we have to act on the nodes that are in the groin before they go through a very degenerative and fibrotic deposition, because the lymphatic vessels that drain the lower limb are linked to those nodes that are disconnected to the pelvic nodes. So this is the site of the surgery we should address possibly as soon as possible. Ask me about arms and groins, but the patient asked me, what about the trunk, hips, and upper torso around the neck? Yeah, these are lymphedemas that can be present, the neck lymphedema. We wrote also a review on the neck lymphedema, especially after cancer treatment. These lymphedemas can be treated, are less common, but as always, around the body, when it's possible to perform a lymphatic vessel, lymphatic venous reconstruction, this is for us the first option when the physical treatments in those patients are not enough. But in general, it depends on what the lymphedema occurred. If it's a primary lymphedema, a secondary lymphedema is the lymphedema, for example, on the trunk is for example in the thorax or in the abdomen. And how deep is the lymphedema? It is subcutaneous or lymphedema in, for example, with planus effusions in the thorax or in the abdominal region. In this case, the analysis and the test that have been done has to be more precise, and the patient should be studied to address the possible surgery. Yeah. But it's a good question, because these are lymphedemas that sometimes in many centers they are very difficult to be treated, and of course the correct diagnosis and planning can help also the surgery to let the patient have good results. Some ask me to perform LE&RN, so single lymphatic venous anastomos with multiple lymphatic venous anastomos at the same time. Yes, we do it. It's possible. I would consider to take all the good structural lymphatics and to anastomos them. As many as we can means more thorough, means better and faster outcome for the patient. Which surgery has been more successful for lymphedema patient? Depends if it's a lymphedema on our registry and investors spinning liposuction, because I saw many patients that were treated for lymphedema with liposuction that then developed a secondary lymphedema. So investors spinning liposuction is a lymphedema is related to also lymphedema, so a lymphedema, as I said before, microsurgery before liposuction. I'm reading some of your questions. A patient from Ghana asked me that there are little services for lymphedema in Canada. Do you see patients from Canada? Yes, we receive a lot of patients from Canada when they have to come, and we had a very good collaboration with the Canadian Minister of Health for patients that need treatment and came to be treated in Italy. Few more questions, sir. I'm happy about all these questions, and eventually I will ask the organizers to send me maybe a list of questions if there is somebody that some person cannot be applied due to the time, but I will be more than happy to give all the answers that the attendees ask. Another interesting question is about lymphoscintigraphy. Ask if this has to be still standardized. I said that. Can you explain the limitation that still exists? It's easy to say. For example, if you perform a lymphoscintigraphy and you perform the injection between the first, second, let's say interdigital space, you study the lymphatic system that is superficial. If you do only directly, you only study the superficial system. If you perform injection in the plantar region or in the palmar region, for example, for the upper limb, where we have the posterior tibial space, then you study the deep lymphatic system. So if you study one and not the other one, you have just 50% of the information. And in case in which you don't see anything, you perform the distal injection, but you don't see the tracer going up, so you don't see nodes, you don't see lymphatics, you can decide, the nuclear medicine, the nuclear doctor can decide to perform the injection more proximally. And in this case, you can see lymphatic structures. So this is an example that in centers that have a high flow of lymphoscintigraphy, it gives a fantastic information. In some other centers that have few experience, the exam can be completely sometimes unuseful. And are compression stockings recommended in nighttime? Usually I suggest patients to remove compression stockings at nighttime, just to feel free. And there are some other, let's say, not really compression stockings, but there are some other, like the helmets that are much easier to use in the night. But usually I prefer to let patients remove the stockings at nighttime. The only exception is that when the patient has performed liposuction very recently, and I suggest the patient to keep the stocking for 3-4 weeks after surgery, also possibly during nighttime. The last question that I answer is this one. 19 years old, 19 years ago, having breast cancer surgery mastectomy. The doctors did not address the lymphedema on my left arm of surgery, saying it's not that bad. After 2 years complaining, I was for lymphedema, massage therapy. As almost 20 years ago, most doctors and nurses had no knowledge of lymphedema results after removing 28 lymph nodes. It's late to know the time lapse and major cause of lymphedema this many years later to reduce the size of the left arm that has the lymphedema. Cellulitis occur about 6 times over the years. So to answer to this, it's never too late. Like I showed at the beginning of my presentation, we should see how the situation, how the lymphatic pathways in the left arm are. There are many possibilities. We can perform, we could perform possible lymphatic venous anastomosis and load axilla, so just a little bit below the site of the 28 lymph nodes removal. We could add also to this to treat the solid tissue lymphatic liposuction, and eventually we could also use the Bible purpose to make a bridge from the site where the lymph nodes were the axilla. But in any case, we should have to suggest you the best possibility and upgrade complete lymphoscintigraphy, ICG test, and of course, I would suggest you to perform these exams after a cycle of physical treatments to, let's say, have a good lymphatic flow from the arm, from the hand, the axilla, so to create the lymphatic drainage, let's say little hypertension of the lymphatic system. In this way, that goes to the axilla, which the lymph node were involved, in which way also the lymphoscintigraphy and the ICG could show better lymphatics. So I am happy and honored, and I hope that you had a good time today. I thank, of course, all the LE&RN team for on this symposium, and of course I'm available for any questions you may raise after we end now. And I go with you with this organization and keep going at LE&RN, because I really love your activities and also the activities of the Centers of Excellence. And I give a strong hug to William Repici, and I hope to meet you soon somewhere around the world.